I have the pleasure of introducing Dr. Art Kidd, an endocrinologist from the Schulich School of Medicine. He was born and raised in Windsor. Dr. Kidd studied sciences from the University of Windsor, and he received his MD from the Queen's University and his fellowship in internal medicine in 1977. He wanted me to muffle that part, but I wanted to make sure everybody knew. Subsequently, he's trained in endocrinology at the University of Toronto for 3 years. When Dr. Kidd began his practice here in Windsor, he initiated the first diabetes treatment clinic locally in conjunction with the Salvation Army, Grace Hospital High-Risk Pregnancy Unit, and its neonatal intensive care unit. And when the metabolic unit were introduced at Hotel du Hospital in 1990, he was the senior physician involved in the implementation. Dr. Kidd has been involved with numerous task force involved with the evaluation and improvement of the diabetic population locally. In addition, he's been practicing medicine. He has held many positions of leadership within the community of Windsor and Essex County over the years. Currently, he is the medical director with the Diabetes Wellness Program at the Windsor Essex Community Health Center, and he's the medical director of Learning Wellness at the Schulich Medical School. Without further ado, Dr. Art Kidd.
You'll notice what I'm going to give you actually is I'm going to run through a lecture that we now give to the second-year medical student class. You'll notice Robbie Stein is listed as the author. Robbie is a pediatric endocrinologist in London, and he asked if I would provide that lecture locally for our local students. He gave me permission to present these slides to a non-medical school audience. I pointed out to him that there were likely to be a lot of educators in the audience, and so he asked if I would make it a little tougher for you guys than it is for the medical students. This is actually a new topic, and what I'd like to do is, as I discuss type 2 diabetes in the pediatric population, I want you to sort of get a grasp for what the implications are when we talk about trying to achieve a healthier lifestyle. So I'm going to be, if this was a medical school class, I'd be going into a lot more details about the etiology and the understanding of different types of diabetes. But this is the issue. This is a real patient, and she is, I believe it was 14 years old, had been obese throughout all of her life, and at the ripe old age of 14, she was diagnosed with type 2 diabetes. Now that may not mean much to this audience, but it means a lot to me, because this is a cover from Time Magazine, 2002, and it was about 10, 12 years ago that the enormity of the health problems related to our lifestyle to the pediatric population became evident. So, in a long, long time ago, when I was a medical student, we looked upon diabetes as being two different diseases, and we still do. The type 1 diabetes was called juvenile diabetes, and as the graph shows, the reason is because the people developing type 1 diabetes were essentially very young people. Type 1 diabetes is called an autoimmune disease, where the immune system, instead of just fighting infections or cancer cells, turns upon a normal organ or tissue in the body and attacks it, and in this case, attacks the insulin-producing cells of the pancreas and destroys them. So type 1 diabetes is notable for the total absence of native insulin in the individual who has to take insulin on a regular basis. That's why it's called insulin-dependent diabetes, because the patient depends on the injected insulin to live. If they stop their insulin therapy, they are dead in 2 or 3 days at most. Type 2 diabetes, on the other hand, is a completely different disease. And back in the day, when I was a medical student, we would say that it typically developed after the age of 40. And it's a different cat altogether. In this condition, the patient is still producing insulin, but not enough insulin to get the job done. And hence, in both forms of diabetes, the diagnosis is made by the elevation of the blood sugar beyond what would be considered a safe level. As our population has changed over the years, so has the population that is represented by each of these two diagnoses. You'll notice the green side has now members who develop the disease after the age of 30. And we recognize that type 1 diabetes can be of late onset, and approximately 15% of the population that develops type 1 or insulin-dependent diabetes does so after the age of 30. I've actually made the diagnosis on individuals in their 80s and plenty in their 40s and 50s over my career. The topic today, however, the worry here is what's happening in terms of the diagnosis of type 2 diabetes, because the rate of discovery of diabetes in the younger population has been growing and is the significant number that we're worried about. Again, back in the day, insulin-dependent diabetes was called juvenile diabetes because only young people developed it, and type 2 was maturity onset diabetes because of the relatively more senior age when it was developed. But you can see that there's been a definite blurring, and hence we avoid the juvenile and maturity onset terminology altogether. So what is the problem we're dealing with? Basically, this is a worldwide problem. But it varies with different population groups. And so that, for instance, in the United Kingdom, it's only about 0.5 individuals per 100,000 that develop the disease, whereas in the United States, it's 6.5. Across Canada, it's about 1.5, but in certain groups, the rate of development of type 2 diabetes skyrockets. And certainly in Essex County, where we're so very proud and pleased with our multi-ethnic population, we have to be even more aware of the fact that that population group is at a higher risk of developing type 2 diabetes. So a little bit more about the epidemiology. The rapidly increasing incidence is in the younger age group. And when you hear, by the way, in the popular press, when they refer to diabetes as increasing in numbers, they're really talking about type 2 diabetes, even though for convenience they just call it diabetes. And again, our native Aboriginal populations have some of the highest rates in the world. Northern Ontario and Manitoba were areas where the original research was done in the world to show how phenomenal that rate of development of type 2 diabetes was. In Manitoba, for instance, 12 per 100,000. And this was typified in the popular press as they pointed out that there had been a regression in our physiques by generation after generation. And you heard the comment that perhaps our children of today will be the first population group that will not live as long as their parents. To give you a better idea of how this problem has been developing in Canada, these are studies from the health population studies that have been done over the years. In 1985, you can see that the rate of obesity in Canadians was the same across the country and was under 10%. By 1990, various provinces were showing that the rate had gone into the 10 to 14%. And as we march through, and these are just about every 5-year intervals, you can see that generally speaking, everything was becoming darker. In 2000, they now were able to provide statistics from the territories, and those statistics were particularly alarming. And they continue to progress. And these data are, in fact, outdated already. So how do we define obesity in children as opposed to adults? Well, in adults, we use a body mass index of 30 or over as indicating that the person is obese. The body mass index is the weight in kilograms divided by the square of the height in meters. In children, it's a little different because obviously as they go through different patterns with their physique as they're growing, the BMI relationships can change. So the definition of an overweight child is based on his BMI for his age. And if his BMI is over 85% for his age, then he's considered overweight. And if it's over 95%, he's considered to be obese. In Canada, the rate of obesity tripled in just 15 years, from 1981 to 1996. The boys went from 15% being overweight to 28.8%, and then from 5% obese to 15% or 17% obese. The girls showed a very similar trend of doubling in the number of overweight and tripling in the number of obese. Indeed, if you look at the prevalence of overweight and obese children in the European and North American countries, you can see that the Canadian statistics do not look very good. And we already heard something with regard to that. So the problem is that the obese child tends to become the obese adult. And with that obesity comes the increased risk of heart disease and stroke. So it's to our horror that we realize that a large number of our very young children are all already demonstrating an increased risk of heart disease because of their lifestyle factors. This is an old graph that shows life expectancy based on your BMI. And for both men and women, it's better to be in the range of 25 down to about 20, with the life expectancy going down. By the way, these are mortality rates, I'm sorry, so the death rate is going up as the weight goes up. There is some elevation when the weight is too low, but that's usually felt to be due to other diseases that interfere with nutrition. So why are children becoming obese? Well, it's basically the fact that there are more energy being consumed than is being burned off. And the obvious social reason, as we know and hear all the time, is our fast food and the tendency for our fast food portions to be increasing over time. So basically, we want our children to be eating more energy than they're going to burn off, because otherwise they can't put on weight and they can't grow. However, in retrospect, it looks like we're a little bit too generous in estimating what would be a healthy amount of calories being consumed. And the net result is that 91% of children are not consuming what's considered the minimum servings of the healthy vegetables and fruits that they should be, but rather they're going after the fast food, fatty foods with total and saturated fats way too high. And we already heard some comments about liquid drinks, and it's 20%. Snacks now account for about 20% of the total daily energy. There's some interesting trends. This is a Quebec study that showed how from 1977 to 1996, there was a decrease in the amount of milk that was being consumed and a much more dramatic increase in the amount of soft drinks. And also there's a physical activity. And a journey of 1,000 miles starts with a single step, but unfortunately our children are not taking that single step. So the remote I can remember my brother and I racing to the TV because the first one to get there got to pick the channel that we would watch. Now it's the guy who's got the fastest thumb. Now, again, a large proportion of our children are watching at least 2 hours of TV per day, and the average total screen time is in the range of 3.4 hours per day. And of great interest is the amount of energy consumed in a population group goes up in proportion to the amount of screen time. And I think we can all envision what's happening there. So how does that be reflected in our population statistics? Well, the more screen time, the more overweight and the more obese the children are. So the Canadian Association for Health, Physical Education, Recreation suggests that our children should be getting a minimum of 30 minutes of physical activity per day. That's defined physical activity as using the great muscles. The Canadian Medical Association feels that it should be even more, that there should be actually 30 minutes per day of compulsory physical education for every child. Unfortunately, across Canada, the schools average more like 60 minutes of phys ed per week, and we know that high school students get to opt out of it very easily. Again, here's that comparison of those European and North American countries, but now we're looking at the amount of physical activity per day, and unfortunately, Canada's at the wrong end of that particular graph as well. So what are the implications of obesity? Well, everyone thinks in terms of heart disease and diabetes, and that's all true. But in fact, virtually every system of the body is adversely affected by obesity. So that there's an increased rate in cancer, both colon and uterine, for instance, with obesity. But the one we're really concerned about, for the most part, is the diabetes. And so I won't go into the details here, but basically, the definition of diabetes has always been related to an elevation of a blood sugar that historically was known to be associated with an increased risk of the complications that we associate with diabetes. And specifically, they originally were specific eye and kidney damage. Canadian researchers have demonstrated that even as you approach the threshold towards diabetes, you do get an increased risk of vascular disease, both heart attack, stroke, and peripheral vascular disease. The numbers aren't important to you, other than for me to say, if you cross a certain threshold, you've attained a diagnosis, and it's a diagnosis for life. So there are the biochemical criteria for diabetes, but then trying to figure out what kind demands a review of some of the things that I've already mentioned, such as the demographics, clinical criteria, and also the insulin level. We can measure insulin levels. The antibodies that destroy the islet cells of the pancreas sometimes can be measured, and if they're there, it makes you more likely to make the diagnosis of type 1, but it doesn't make it conclusively. It's much more the whole picture, and especially the family history, that counts. And we used to think that a severe complication of type 1 diabetes, diabetic ketoacidosis, meant you had that diagnosis. We now know that a large percentage of patients with type 2 diabetes can be sick enough to go into diabetic ketoacidosis as well. In fact, the first teenager I saw with diabetic ketoacidosis was about 25 years ago, and I misdiagnosed him as type 1 for about 5 years. So it's very seldom under the age of 9. The visible minorities that are common in Essex County. My daughter is, in fact, a Hispanic. The family history, type 2 diabetes, is extremely common. 50% of the children developing diabetes will have a family member with type 2 diabetes. The obesity rate is not 100%, but in the range of 90%. And there's a skin condition called acanthosis nigricans, which translates to mean that the skin is soft and dark. And you may, as you're walking around, see some kids with a darkening on the back of their neck, and you think they didn't wash, but in fact, that's a very serious sign of problems with their glucose metabolism. And it's most commonly seen at the neck. This is just a review of studies that were published a while back, and I draw your attention. Robbie Stein was training in endocrinology at the Hospital for Sick Kids when they published this study of 41 children with type 2 diabetes back there in, I think that was 2002. And quite frankly, we probably have more children than that in Windsor with that diagnosis now. And that just shows you how it's been spiraling out of place. Basically, again, type 2 diabetes involves a problem of insulin resistance, so that the pancreas has to produce more insulin. That's similar to trying to push a 57 Cadillac with a 57 Volkswagen engine. And what happens over time, and the risk factors all contribute to this, is that the islet cells begin to burn out. And as they burn out, the insulin levels drop. And as the insulin levels drop and the resistance is still there, inevitably, you're not going to be able to maintain normal blood sugars, but you're going to get the blood sugars starting to rise and make the diagnosis of diabetes. And that's a failure of the pancreas, not as complete as in type 1 diabetes, but it can be pretty dramatic. The difference is in type 1 diabetes, it's a pure insulin problem, a pure islet cell problem. In the rest of the cells, the rest of the body is normal. However, in type 2 diabetes, if you think about it, it's a weakness in the metabolic system of every cell in the body. And in the treatment, we have very little treatment. There's all sorts of pills and other injectables and insulin that we use with type 2 diabetes in adults, but very few of them have been used to treat children or have been studied to prove their safety. So with children, it's lifestyle modifications and hope that you get the hemoglobin A1C, which is a measure of overall blood sugar control, into an excellent value and keep it there. But most often, you don't succeed, and the hemoglobin A1C is too high, so you add in metformin, which has been around for 30-something years, great medication. But if the metformin fails, which it does, inevitably almost, within the first few years of the diagnosis, you really have no choice. You can't go to the other adult medicines. Instead, you have to go to insulin. Insulin's a great drug. It's just inconvenient. I want to go back to lifestyle and actually pretty well close out with this. There was a study published in the New England Journal of Medicine about 10 years ago, 11 years ago, called the Diabetes Prevention Program. And what they demonstrated was that if you took people who were at risk of developing diabetes because their blood sugars were up a little bit, but they hadn't crossed that threshold, if you put them on metformin, which would help the natural insulin work, the rate of development of diabetes was reduced by about 32% over the course of the study, which is pretty dramatic, remembering that once you develop diabetes, you have a significant risk of serious eye and kidney problems. However, they also had an arm to this study that looked at lifestyle changes. Now, the important thing for you to realize about this lifestyle changes is how little it was. The expectation was that they would work with dietitians to drop their body weight. In general, in the group where they vigorously pursued this, the body weight drop averaged 7%. So that meant a 200-pounder went down to 186 pounds. Not exactly earth-shattering. Well, what was the exercise component in the lifestyle? It was a half an hour of walking at least 5 days a week. Now, was this power walking with heavy weights in the arm? No. The individuals were asked just to walk fast enough that they could feel it, that they could tell that their breathing had changed. And that combination, no medicines, just better eating with a 7% weight drop, and remember, 90% of these people were either overweight or obese, and they, through lifestyle changes, dropped the rate of development of type 2 diabetes over the course of the study by 58%. So it was almost twice as effective as using a pill. And that's why, really, when we are talking about type 2 diabetes and the fact that it's lifestyle impacting on genetics, it's lifestyle, lifestyle, lifestyle. Thank you.